Good morning, everyone. People are just filing in, and I would invite all the participants to, if you can safely do so, introduce yourself in the chat and where you're zooming in from this morning, so we can get to know one another. Welcome. Thanks for joining. Okay, good morning, everyone, and welcome. Thanks so much for joining this morning. As participants file in over the course of the next few minutes, I invite everyone to introduce themselves in the chat so that the panelists can know who's in the Zoom room. And we do tend to have people trickle in throughout. It's nice for them to see who else is here as they're joining. My name's Danielle Martin. I'm a family doctor at Women's College Hospital. I'm the chair of the Department of Family and Community Medicine here at U of T. Before I welcome today's guest, who I'm very excited to introduce to all of you, I want to talk a little bit about the purpose of this series and about the wonderful image you see on screen, which Dr. McKenzie commented on as we were getting ready to go live on the webinar. This speaker series, as many of you know, many of you have been able to participate in the past, is called New Horizons, and it's all about dreaming big about the future of primary care, family medicine, and our department. In part, I think this series is an acknowledgement that we need to challenge ourselves to reevaluate our assumptions, and we need to draw fresh perspectives from colleagues in the broadest possible range of fields. We've had speakers from the arts, from public health, community activism, social sciences, and more. I'm really excited about the next two speakers as well. So before we get to what I know is going to be a superb conversation with Dr. Kwame McKenzie, I just want to say a few words about this incredible piece of art and share with you all that I had the opportunity to go to the McMichael Gallery last weekend with my mom to see Meryl McMaster's current exhibit called Bloodline, which is running there and which includes, among many other spectacular images, this photograph, which I just think is so evocative. And is in part the inspiration for our speaker series. This piece is titled Lead Me to Places I Could Never Find on My Own. It's the second of a two-part series, and it comes from a series called As Immense as the Sky. Meryl has graciously given us permission to use this image as part of our reflection on land and on indigeneity and on truth and reconciliation as part of this speaker series. And this image, she tells us, and I'll quote her here, that stories of the constellations have been passed down over generations within both Indigenous and non-Indigenous cultures. Humans and animals have used the stars to navigate for thousands of years and still do so to this day. As the stars become hidden by light pollution, we start to lose our way. So this image was taken at the Badlands in Grasslands National Park, which is a dark sky preserve where you can really see the stars. And the birds perched atop her hat are bunting birds, indigo bunting birds, who use the stars to navigate. And so it's really just a commentary on different ways of navigating to get to where we need to go. And I can think of no better person than my colleague and friend, Dr. Kwame McKenzie, to challenge us in this kind of way. So allow me to introduce Professor McKenzie now. Dr. Kwame McKenzie is CEO of the Wellesley Institute, which is an amazing organization. And I'll put the link to the Wellesley Institute website in the chat. Wellesley Institute is an organization that does research and policy work to improve health and health equity in the Greater Toronto Area through action on the social determinants of health. Dr. McKenzie is a full professor in the Department of Psychiatry here at our own University of Toronto, and he's also an international expert on the social causes of illness and the development of effective, equitable social policy and health systems. He's also the Director of Health Equity at CAMH, the Center for Addiction and Mental Health, and he's a practicing psychiatrist. As a policy advisor, clinician, educator, and academic with more than 240 peer-reviewed papers and 6 books, Dr. McKenzie has worked across a broad spectrum to improve population health and health services for 3 decades. So we're so excited to have Kwame with us today. And I just want to say we tend to use the chat function for interaction with one another and reactions and commentary, and please use it liberally. But if you have a question for our speaker, and we're going to have lots of time for those, please enter your question in the Q&A, and you can upvote the questions of others in order to prioritize that. And with that, it's a pleasure to hand over to you, Kwame. Thanks for joining us.
Well, thanks very much for inviting me. The more I hear, the more it sounds like there's some wonderful things happening in the department, and the idea of looking outside to get a mirror on what you might do in the future with New Horizons is just spectacular. And the fact that you can get people to turn up at 8 o'clock in the morning is extraordinary. It's really extraordinary. I'm going to share screens, not because I'm going to do a long presentation. I'm going to do a very short presentation which just starts introducing the ideas and some questions, because I'm not saying I know what family practice needs to do, family medicine needs to do to move forward. I wouldn't want to say I'm that sort of, I'm not a family physician, so I wouldn't deem to say that I know, but just to introduce some of the themes, some of which you may have already talked about, but these are things that have to be navigated moving forwards. So let's share screens. Perfect. So this isn't a setup. I didn't know what was happening before, but I am starting with a different indigenous saying, and this is from the Maori. And the Maori have this idea of kamua kamuri. And kamua kamuri is translated as "we walk backwards into the future." And that image has stuck with me, and I try to use it when thinking about the future, because what we normally do when we're walking into the future is we look to our pasts. We try and fix things that have happened in the past, and because we are looking at the past, we don't experience the present completely, and we're really not looking in the future. And so it's like we're walking in the dark. We stumble over obstacles which are predictable, and we don't take the opportunities which we could have predicted if we were looking really at the future rather than looking at the past. And so when I'm thinking and trying to think about the future, the first thing I try and do is see if I can move myself by 90 degrees, so sort of walk like a crab. So I'm looking into the past, I'm experiencing the present, but I can actually look to the future. And other people have been doing this. So in the UK for the last 15 years or so, they've had a bunch of foresight projects where they're trying to get academics and change merchants and thinkers to think about the future and what's needed in different topic areas. And when they're thinking about the future, they really come up with 4 or 5 areas that they say we have to think about. And some of these will be things that you've covered, some of these will be obvious, but some less obvious. So the change in demographics, older population, aging population, and a more diverse population is a thing that family medicine has to navigate if it's going to move in, if it's going to have a successful future. There's also a change in attitudes and expectations. People expect to live longer and live healthier. So there's more expectations for health from the population in general as we're moving to the future. There's also a change in attitudes that we have to navigate. People want more personal choice. People want better customer services. People are a bit skeptical about people who call themselves experts, and people want to co-produce solutions. More and more, that is what's happening. This is how people are changing their attitudes. They are not they're less grateful, and they're more demanding. And they're more demanding of new technology, which they expect to come quickly and to be personalized. Medicine, like your phone, personalized, changing all the time, and available. And so these are things that people expect. And then we have witnessed increased social environmental volatility and pandemics. And this is things that are in our current view because we have just had more of these things, and all of these things lead to more mental health and mental wellness needs. So the frustration at not getting what you want, the poorer customer service, the volatility in society, and also pandemics, the desire for more health, better health, but other people to look after people who are less healthy, the changes in society and the churn of change, all are things that we see leading to more mental health and wellness needs. And you saw this in the pandemic. 50%, and we're in a situation now where 50% more people want therapy. We have a 300% increase in youth helpline use. We have unprecedented rates of burnout. We have increased violence, and we have long COVID with the mental health issues that are linked to long COVID. All of this, despite the fact that we had one of the best pandemic responses that there was in the Western world. And so this is the outcome when things have gone well. So it helps us think about the future. And I talked about sort of volatility and planet volatility. And I know you've already spoken about global warming, but I wanted to try and crystallize it, because global warming can be very big. This is a little study that we did in a place called Lewes, which is in the south of England, a solidly middle-class area in the south of England, and the river that goes through the centre of the town flooded. And we did a simple case control study 9 months after the flooding, where we matched houses which had been flooded with houses that hadn't been flooded, and we wanted to look at the health outcomes. And one of the things we found from those health outcomes was that there was a 50% of the people who had been flooded were depressed 9 months after the flooding, compared to 15% of the general population, so a threefold increase. So we had 50% of people flooded. And when we looked at the people who presented to family doctors with physical health problems, we found that there was an increased risk of earache, gastroenteritis, and rash. But we found that when you took people's psychological distress into account, a lot of the increased risk just disappeared, became not significant. And so psychological distress was a better predictor of earache, gastroenteritis, or rash than whether, when you were flooded, sewage came into your house, or whether you had no water supply, or even the height of the water. So mental health was really important, and was really important for presentations of physical health. And I think when we're looking at the impacts of global warming, just like when we're looking at the impacts of any other extraordinary situation, we will see significant physical impacts, but we will see huge mental health impacts. And there will be a question of how family medicine is organized to deal with that. But one of the things that's more local is a question of how family medicine deals with the demographic shift in in Canada, which is that we are going to be a more and more diverse population. And historically, our diverse populations have not had equitable outcomes with the medical system. It's not only family medicine, but it is our whole medical system. And this doesn't need to be the case. And I just wanted to show you a quick case study of what happens when community and family medicine can work together. I'll take you back to March 2020. High rates of COVID in the UK and the USA, which we found in Black populations. Then we had the death of George Floyd and the rise of Black Lives Matter. And locally, we were trying to find out whether there were similarly high rates of COVID in Black populations in Ontario, and to pressure government to try and find out, to start collecting data. There was a birth of the Black Health Equity Working Group, which aligned community, academics, and service providers to try and push for equity. And the aim was to produce a data-driven quantification of disparities, if there were any, so that we can monitor them, get resources in the right place, and we can monitor the impacts of any changes that were made. We wanted an evidence-informed, community-driven pandemic solutions. And you'll remember that when those data came through, we found, before the data came through, when we didn't have individual level data, we only had area level data, that we were able to see that there were hugely increased rates of COVID-19 in the northwest of Toronto areas that were, and areas that were more racialized. And actually, the percentage of racialized populations in an area was the best predictor of COVID rate. This helped convince public health units to start collecting data, and then by June, the province of Ontario changed the law so that data was collected for people who tested positive, and with these results and the data coming through, some public health units decided to consult communities. And this consultation with communities, communities wanted to go to consult through people who they knew well, and those were the community health centres. They trusted their community health centres, and because of that, the Truth Community Health Centres were able to ally with communities, understand communities, work also with public health units, hospitals, and government to try and develop real solutions, and that different population health, public health response that was targeted to racialized communities, exactly what we were trying to achieve. And we published the results in the Lancet, eClinical Medicine, which is a Lancet publication. So what this shows is the rate of COVID-19 in racialized populations, different racialized populations compared to the white population between June 2020 and December 2020. So to make it easier, perhaps we'll follow the blue line, which is the Black population. And if you start back in June 2020, right on the left-hand side of the graph, then we have 6 times the rate of the white population, which goes up to 9 times the rate of the white population by August. But that is when the community-driven public health strategies started coming in. And as they came into play over the next few months, September, October, November, December, you can see a decreased rate ratio of COVID compared to the white population. So by December, there was still a disparity, but instead of it being 6 or 9 times the rate of the white population. It was just 2 times the rate of the white population. And whether you're looking at the Latin American, South Asian, or Southeast Asian populations, the rates in December were lower than the rates in June, demonstrating that collecting data, analyzing the data, making the data transparent, and working with primary care communities and communities together, we can decrease disparities. And we will need to going forward because of the increased diversity that we know is the future of Canada. So the questions that come to mind, not just from these 2 stories, there are many, many stories, but really from thinking about futures is how can family medicine gear up for the challenge of climate change? How can primary care do a better job supporting people with mental health needs? How can family medicine improve outcomes from increasingly racialized population? Because there are significant disparities in outcomes, and some of those start in primary care. And on top of that, how does family medicine meet the needs of a more demanding and more skeptical public? So I'm going to stop sharing. These are just some ideas of things we might want to talk about, because they're some of the areas that we might want to navigate, that family medicine will have to navigate in the future. I'll stop sharing. Thank you.
Thanks so much. Very rich food for thought, and we're so grateful for your expertise. I want to come back to something that you said about community health centers and invite you to push us as hard as you like on this front. We know, of course, that community health centers have a mandate and have funding and have a physician compensation model that is specifically geared to serving a diverse and underserved high needs population. But we also know that close behind community health centers, certainly in the GTA, the group who tend to take care of racialized populations are actually the solo practice GPs in the community, often who come from those neighborhoods and communities themselves, and who don't tend to have the interprofessional supports that you might see in a family health team. I'm wondering if you can say a little bit about why you think that the community health centers were so essential to the vaccine rollout in community, and what would your advice be to family medicine as a whole and to academic family health teams as we consider how to orient ourselves, do that 90-degree crab walk you described, to get ourselves more in the mix of serving the people who need it the most?
So I think one of the things that we're doing, sometimes people say that Canada, when things happen first in the United States and then they find their way into Canada. And if you're from the UK, you sometimes think, well, just a second, didn't we do this a while ago? And are the same issues now coming into Canada? And I think Canada's special, so I don't think we need to necessarily think like that. But on this particular issue of solo practices in areas that are predominantly racialized, being run by people who are predominantly racialized, this was one of the things that we found there was a lot of in the UK. And the practitioners died out over time, and they left huge gaps because the system had relied on people, and I relied on them when I was a kid, going to terrible family practice, actually, with incredible long rates and no appointments and no quality control because no one else would work there. And so I would say we have to work out whether we're talking about how we deal with remote and rural or the north or racialized populations in inner cities. We have to work out how we take our important resources of family physicians and family practice and we spread them. And there are places, and I think we have to think about this, and we have to think about not only how we spread them, but how we spread teams, because the evidence is that solo practice may see people, but it's much more difficult to get the quality outcomes that you get in a team, and also, as the demands rise, the team and the allied staff become incredibly important for meeting the needs of people, and also making sure that we're using our resources in a reasonable way. So I would be saying, yes, the solo family practices, they've done a great job, but it's not a long-term model.
So just to pick up on this concept of team then, and I'm reminding all the group also that you should feel free to put your own questions in the Q&A, and we'll open up shortly to that. But on this question of team, and coming back to your mental health example with the flooded river, you're a psychiatrist. As well as we do, that access to mental health services outside of physicians or even physician health services is really difficult right now in the province of Ontario. And most mental health issues are dealt with in general practice and family medicine. How can we begin to get the attention of government funders to try to increase access to publicly funded mental health services? Because certainly for a solo practice person, or even a physician group who don't have access to publicly funded social work or psychology, and are serving a high needs population, it's a major source of burnout for our discipline.
Yeah, and I totally understand that, and I totally agree. I think there is, just like this sort of visioning in family medicine is important, similarly the visioning in mental health is important. And I do believe at the moment our mental health system is not geared up for any of the challenges that are ahead. We believe at the moment that we can treat our way out of a major crisis, that we don't need to task shift, that we don't need to move upstream, that we don't need radical social policy change. We believe we can just do more of the same. And it's not working. It didn't work in the last pandemic, and it won't work in the next pandemic, and it won't work and it won't work when we've got climate change. Yes, we need a huge increase in access to psychological supports. We need an increase in psychological literacy. We need an increase in preventive work to increase both individual but also community resilience. But we need policy resilience as well. And so, yeah, we need a huge change in the way we deliver mental health services. And if we can do that, that helps family medicine. So when I'm saying family medicine needs to work out how it's going to deliver mental health services, that doesn't mean it has to deliver mental health services. It may need to advocate with community mental health for changes in models, for changes in access, for a simple thing. A whole bunch of people have EAPs, sort of employee access programs for assistance programs. Those sort of employee assistance programs don't necessarily have a competent mental health side to those programs. And when they do, they don't necessarily link to family medicine in any way. So you've got maybe half your patients half the time who can get access to various types of services, which you don't see. So nobody at the moment is saying, actually, it seems really weird that your whole mental health allotment for a year pays for 5 sessions. when you know that you need 12 sessions of CBT, 8 to 12 sessions of CBT to get well. So there has to be some work to try and regularize that and say, well, if you're going to do it, then there's sort of psychological wellness means that the EAP has to actually properly meet the needs of people who are in work. EAP probably also needs to think more about prevention, and it's extraordinary that while family medicine is thinking about this, and while mental health is thinking about this, and while the United Way are thinking about this, and while the YMCA are thinking about this, that everybody isn't thinking about it together. The recent depression guidelines in the UK, frontline treatment for mild depression, exercise. So why can't family medicine prescribe exercise? Because nobody's joined up family medicine properly with the YMCAs to be able to offer the program, or with other community gyms. There are loads of things you can do if you radically rethink mental health. But the mistake we make is we think, okay, how can we just increase the capacity of family medicine to do this? That is looking at the past rather than looking at the future, and not thinking there are massive changes we could make that will allow us to do this.
I completely agree, and I would add that we did have Medhat Madi, the immediate former CEO of YMCA, at a previous New Horizons event, and had a really amazing conversation about how family medicine and the Y might collaborate together. I mean, the Y is the biggest deliverer of childcare in the country, and as a place where people congregate in all communities, including high needs communities, a place where we can access seniors, we can access youth who are at risk, and the list goes on. And I think that those collaborations could be really rich, and maybe with Wellesley also, because I think on the research and data front, which I do want to get to, there's a lot of analysis along social lines that family medicine research is interested in partnering around to do a better job of aligning our research to community needs. You mentioned radical social policy, and so before I go to the Q&A, I have one, maybe it's only slightly cheeky question for you, which is, when you think about equity and health equity in the GTA, if there was one social policy, one upstream policy that you could wave a magic wand to see implemented to close the most critical gaps, which one would you pick?
Okay, so Daniel, you know me well, so I'm the sort of guy that if you say there's one, I say, okay, I've got two. So,
I'll take it. I'll take two.
Okay, so the first one is some of the work that's been done at the Wellesley has been around what resources you need to thrive. And so we've worked out how much money you need to be able to live a healthy life in the GTA, and other people have done it in other places, in Thunder Bay, in Guelph, and also in Alberta. People have done the same. And currently, our policies, whether they're our social assistance policies or our tax policies or various policies we have, do not use health as the level at which we start thinking about adequacy. So poverty levels and all of these other levels, they are not based on health. And so one big change that I'd like to see is that the aim is not to reduce poverty, we have to do that, but the actual aim is to get 100% of the population with enough resources to live a healthy life. Half the people in the GTA do not have enough resource to live a healthy life. That is the basis on which we then get the other impacts of of, say, for instance, where the climate changes we know they're going, or pandemics or whatever, they exacerbate social divisions. If we can shrink the social divisions, and if we can make sure everybody has enough resource to be healthy, then I think we're in good stead. So that's the first thing. The second thing I would say from a social policy perspective is I would make it illegal to make social policy that doesn't drive equity. So we actually had a pandemic strategy that we knew wouldn't work well for some people. We have a hospital and health strategy at the moment that we know will leave people behind, and that is legal. I don't think it should be. And I think if public organizations had to promote equity and had to make sure that their services work equitably, even the CERB, when the CERB came in, that didn't work equitably. We pushed the federal government and they improved it. If we stop making those mistakes and we really push towards equity, that is going to be one of the biggest things we can do to put ourselves in a good position to deal with any shocks that are in place, that are coming our way. And I think it's quite important. We can go small, or we can actually go and say, like, why do we have poverty? It's actually not necessary. We can get rid of that. And why do some people make incredible amounts of money where other people haven't got enough money to be healthy? We can do that. People can still make big money, but we can still pull everybody up to the point where they're able to have enough resource to be healthy. And that does happen in some countries. It does happen in some of the Scandinavian countries, and they're smaller economies than ours.
So for those who are interested, I put the link to the Thriving in the City program or project of Wellesley Institute in the chat. I think this notion of not just talking about poverty lines, but talking about what is the income needed for a person to thrive and be healthy is a really powerful concept for those of us in medicine to reflect on. I'm going to go to some of the questions from the crowd and remind everyone that if you have a question, please don't put it in the chat, put it in the Q&A. And if you like someone's question and you want to hear it answered, you can upvote it so that we can try to get to the questions that are most that the group is most interested in. So we have a question related to whether we're ready for this population demographic shift that you have described with respect to diversity. The person asks, are medical schools, the College of Family Physicians, the OMA, federal and provincial governments, like all those many stakeholders, really thinking about how to serve a more diverse population in our health systems? I'm curious if you could reflect a little bit on that.
Well, I think it's a wonderful question, so thank you for the question. And the surprising thing when looking at in a country that says diversity is our strength is that we haven't worked out how to work that muscle. And so we haven't at the moment got to the point where we have the educational, not the educational tools, because actually a lot of the information is out there that could be in medical schools. And there is the Black, say for instance, there's a Black Education Collective in U of T who are bringing out a whole bunch of educational resources and trying to work with colleges to upskill people who are setting the curriculums, and actually for medical curriculums actually increasing producing core competencies that are going to be tested in exams around Black health. And so these things do exist, but it shouldn't just be Black health. We should have this across the different groups. We should reclaim our medical training so that our medical training actually reflects the needs of the population, and the needs of the population are for a medicine that understands the differential needs and the differential presentations of medical illnesses, but also how different groups interact with medicine in different ways and have different needs and desires. And so we have to become more flexible. The information's there. The readiness is getting there. And I do believe that though late, we'll get there. But yes, the thrust of the question of can we do it? Yes. Is the information there? Yes. Is it being used? No. Could it be used? Yes. Do we need to do more to advocate for that? Most definitely. But it is interesting that TMU are building a medical school, which will, I think, first group going in 2025, specifically trying to focus on medicine in a diverse world and for a diverse population. And that's very exciting, but it's not going to be enough. If the TMU work manages to change everything else, then we'll be in the right place. Because, was it 1 million newcomers last year? And that is what Canada is the strength that Canada has to build on.
I completely agree, and I don't think that any medical school can or should. We don't want any individual school, our own included, to own the diversity agenda. Everyone needs to participate in advancing that equity agenda in education, and it links to one of the questions that has been posted in the chat around training of our family medicine learners. And so, what are the realistic things we can do to mentor and encourage family medicine learners to go into practice in higher needs communities? And an example is raised of how difficult it is to recruit family physicians to a family medicine clinic in a high needs neighborhood, even though it's a family health team and it has interprofessional supports. So what are some of the solutions? And the person says, do we need to train more in the community? Do we need to recruit more from the community? Do we need to put more supports in place for physicians? Do we need to do group recruitment? Like, what are some ideas that you might have for how we can do a better job of ensuring that when people graduate from their family medicine residency, they actually go into practice in the neighborhoods where they're most needed?
I think that all of the things, it's a great question, all of the things that have been said are really good ideas, but they are based on the idea that in extreme circumstances that everybody is going to have choice. And it's not 100% sure that that's how resources are going to be allocated going forwards. And at the moment, we are a profession who has choices and we make decisions. We want to go here, we want to go there and stuff. It's not 100% sure that that's the way it's going to go in the future. Yes, if you recruit in more diverse populations, more diverse populations, they're more likely to then work with other diverse groups. But you have to be careful that you're not really talking about the ghettoization of medicine in certain ways. So I think there's some thinking to be done by family medicine in general, so that it doesn't get regulated, because that is what governments do when they have difficult problems, and they have groups who start saying, you know what, we've got political power now because there are enough of us and we want this. And so I think we've got to be really thinking about how we develop our services so that they meet the needs of people. And incentives don't necessarily work as well as you think. But it may be that there's not as much choice going forward in the future. It may be that you're just not allowed to set up your shop wherever you want to, and that there are only certain places where there'll be growth.
Yep, fix the problem or have it fixed for us, sometimes in ways that people won't like with respect to their clinical autonomy. I think that's a real risk that we need to have our eyeballs on and challenge both to our education community and to our practice community to figure out what are the incentives that we might shape to meet community needs, so that we don't end up in a situation where people are using a big hammer for a quite precise shape of nail. Go ahead.
There is an underlying question that we have to have, and we all have to reflect on ourselves. What does it mean as a profession that is a public service that we don't want to be places where we're serving the public? That is how a politician will put it, right? And some of the picture we have of ourselves as being, the good guys and the good girls who are, we're good people because we're doctors. Well, people might not agree with us if we're in a situation where we don't go where it's needed, and with all of the talk that there is at the moment about the difference between public and private, people will be saying, well, yeah, they're private non-profits who are cherry picking where they're going to be. Is that what we want? And I'm not saying that's the situation. I'm just saying that you can imagine some people spinning it that way. And so that is something that we have to think about. What does it say about us, and how does that really land in the general population?
Well, one of the topics that has come up and that we had a hot debate about at a prior New Horizons event along the lines of that public-private divide is virtual care, which of course can be used to help to close and address equity gaps. I know that's a part of your clinical practice, or it can be implemented in ways that really widen equity gaps. So we have a question in the Q&A about, where do you as a psychiatrist see patient self-management and virtual care fitting into the solutions for mental health and family medicine? And can these solutions adequately address more mild or lower acuity problems and reduce wait lists? And how might we integrate virtual care and patient self-management into family medicine in ways that don't inadvertently or advertently make equity gaps worse?
Yeah, no, I think that's a fabulous question. I do think that over the pandemic, one of the things that did happen is that there was a big change and a quick change over to virtual care in mental health. And most of that was done based on no evidence whatsoever. And there was a post hoc analysis of some of what we'd done to try and work out best practices, and there are various best practice guidelines in this. But it's interesting that when all of that work came through from the CIHR, almost none of it looked at racialized populations. And so we were back to this idea of an intervention coming out quickly, an innovation coming out quickly, but actually most innovations increase in equities unless they are specifically developed to decrease inequities. And people weren't thinking about inequity when they brought in those sorts of virtual care. So I think that really thinking through what virtual care and how you can culturally adapt virtual care to meet the needs of different populations, and what mitigation strategies you need to put in place to make sure they're equitable is needed. We have culturally adapted CBT for the South Asian populations, for African origin populations, for Caribbean origin populations, for Spanish populations. That hasn't made it into virtual culturally adapted cognitive behavioral therapy. So there's that one needs to do. But I would probably go further down the line of thinking, if we're still thinking at the individual level, at understanding what health literacy and mental health literacy looks like for different diverse populations. And before waiting to get to a problem and needing self-management or digital care, I would be thinking about what we're doing in schools and how we are trying to create healthier and more psychologically resilient kids, right? I would be thinking about that. And when I'm thinking about that, I'm not just thinking about teaching the kids skills, I'm talking about teaching the schools how not to traumatize the kids. Some of the things they do in schools are just, they don't work very well. And there was a sort of safe schools strategy out in Australia, which tried to do that, which tried to think through sort of how do you set up a school to promote psychological wellness. And if you start there, very much like I think the Finnish model, where they have incredible outcomes by producing rounded kids, incredible academic outcomes, and incredible psychological resilience, you get a lot further. So there's all of that needs to be done. There are questions about whether you fund schools in lower income areas at a higher level than in higher income areas. We currently do the opposite. So there are questions about how you do that and how you set that from a public policy perspective. And then there are questions about how you use virtual care and self-management as a bridge to promoting sort of more equitable access and more equitable outcomes for diverse populations, but it's not necessarily the solution.
I think that's really wise. And I wonder if it relates actually to, I think, what will be the final question of the morning, which is, and there's some lively debate around solo practice, which I really appreciate, both in the Q&A and in the chat.
Sorry about that.
No, it's good. I mean, I think we need to push ourselves to ask, like, is this the model? And if it's not the model, how do we move in ways that don't leave practitioners behind and don't leave patients behind? And one of the questions that a thoughtful guest asks is about simplification, that healthcare keeps growing in complexity, in the resources we require, in the modalities of therapy, and the diversity of people, the languages that, now we've got the aging population and administration and technology and all of this stuff, and it just keeps kind of growing and growing and growing. And perhaps the team-based model is an example of such growing complexity. Do you see a time where we might let family medicine or encourage family medicine to become more simple? Can we imagine a simplification of family medicine, like a slow medicine, like as to the slow food movement? Is there a way to slow some of this down and kind of get back to the core, especially given that we're going to have fewer younger people taking care of a lot more older people as the demographic shift continues? So any thoughts on simplification?
That is such a wonderful question. And I'm not sure I have an answer to that. It's interesting. I actually thought team-based medicine allowed simplification of certainly the clinician's job, because one of the problems with the way medicine's gone is, whether it's this test, that test, this intervention, that intervention, this subspeciality, that subspeciality, this clinical guideline, that clinical guideline, is everything that needs to be done seems to center on the clinician, the physician often. And so the physician's job has become very, very, very complex. And myself, I'm a big supporter of family medicine. But I do think it's an extraordinarily difficult job. Psychiatry is much easier, by the way, but that's another matter. But I actually thought team-based family medicine allowed clarity of who does what and gave an opportunity for simplification. I actually also thought that protocol-driven family practice which is coming more and more to the fore, also allowed much more clarity. If all of that allowed the family physician more time to add the added value, which is care, and then I think that not only would patients be happier, but I think that we might be happier as clinicians, being able to do the things that, when properly trained, we're good at, and which actually make us happy. So I understand this idea of this. Can't it all be more simple? Probably not. Mm-hmm. Can we simplify what we do by working with other people? Oh, yeah.
I like that concept a lot. And one of the groups that I think we will see joining our teams more and more are peers. And so I'm going to put in a shameless plug for the next New Horizons event, because at that event, we're going to be talking about two incredible programs, one in the emergency department and one in family practice, in which peer workers are the front line. And so please mark your calendars for April the 28th from 8 to 9 a.m. to learn about the future of peer support in mental health and in prevention and wellness, so that we can think about what is the way that the teams might include community members and patients themselves who can support one another on their journeys to health, rather than bringing everything back to the family physician or other regulated healthcare provider. Kwame, Dr. McKenzie, I want to say a huge thank you. Thank you for, most importantly, for the amazing work that you do and for the incredible work of Wellesley Institute. And I hope that our Department of Family and Community Medicine will be able to deepen our collaborations with Wellesley over time in the area of research. Thank you for your clinical work, for your leadership on health equity in Canada. And thank you for getting up early to spend an hour with us this morning. We're really grateful for your insight.
Well, thanks very much. My pleasure to be here. I hope it's been helpful. I think I'm leaving with more to think about, which is great. So, just some great questions. I know we didn't get to them all. I did try and follow the chat a bit to see what was going on there, and there's lots to think about. I did want to make clear that I am not a family physician and not an expert in being a family physician. And these are just my ideas, but I hope that they will help us in the difficult road we have ahead.
Absolutely. Well, have a wonderful day, everyone, and happy Friday.
Thank you.